I will start with the ORCID. So in our sleep lab is opioid-induced central sleep apnea. This was a young lady, 26 years old. She really had bad luck. First, she had bone cancer surgery, then problems with the hip on the contralateral side. There was a nerve lesion after this surgery, and she developed severe chronic pain syndrome, and she was bound to wheelchair, had very high doses of opioids. And you see the breathing pattern. She usually had 2 breaths, a short, pure central apnea, this is heartbeat, and a very high AHI with short apneas. What's important in opioid-induced central sleep apnea is to measure CO2, because textbook knowledge is opioids may lead to hypoventilation, but this is not very often the case. Most of opioid patients we see have normocapnia or even hypocapnia. Also, this case, she was normocapnic. We have to try CPAP first, and when you have seen the breathing pattern, that's what we expect. It doesn't change at all on CPAP. So in this case, we applied adaptive servo-ventilation because she was normocapnic, short the pressure settings. So we have the variable EPAP, which works like an auto CPAP device, usually from 5 to 12. Then we have the pressure support. We usually set the minimum to 0 to avoid triggering problems when there are no events, so different to the SERVE-HF trial, and maximum pressure, inspiratory pressure support, usually 10 is enough, and the default automatic backup rate to ventilate during central apneas. And on ASV, the patient had a good response. Most of the time it was pure ventilation, like BiPAP ST, and in REM sleep, when we have the likelihood for central apneas is lower, we saw the spontaneous breathing of the patient, and actually the sleep pattern was not optimal, but it improved significantly, and also the patient had a symptom relief, and the excessive daytime sleepiness improved in this patient. The statements from the task force paper, number 1 is to reduce the opioids if possible. We had some success in this case, and therefore we have to restudy sleep apnea in this young lady. And most data suggest that both ASV and bilevel positive pressure are superior to conventional CPAP for elimination of opioid-associated CSA. And then is the question, when do we use bilevel PAP ST or when ASV? The task force formulated the members of the task force use bilevel PAP ST or other stimulants in normal or hypocapnic CSA related to heart failure with reduced ejection fraction if adequate trials of indicated therapies fail. So that means we only use BiPAP ST in hypercapnia because this is the indication it was built for. And this statement is based on Teschler's study from 2001 in heart failure patients, where several therapies, oxygen, CPAP, and ASV, led to a normalization or increase of the low PCO2, but with bilevel PAP ST, usually we ventilate too much in these patients and fail to normalize the PCO2, and that's why we don't like to use it in hypocapnic patients. So this is the main message. So we have to distinguish between normal hypocapnia patients in central sleep apnea, and another important point. I think we should not treat central sleep apnea with an AHI of 6 or 7. I think the relevant severity begins above 15, although this is, of course, also arbitrary.